All right, I guess I'll go ahead and get started. Welcome, everyone. It's so incredible to have so many of you joining us. Thank you for being here today. My name is Paula. I'm a clinical research coordinator and an incoming medical student based in Los Angeles. I'm also a member of Right to Health Action's policy team and represent Right to Health as part of the Public Health Jobs Now Coalition, a group of organizations that are working collectively to advocate for a national public health workforce. Right to Health Action is a grassroots movement of volunteers dedicated to pragmatically fighting for health equity. We came together as a team in response to the COVID-19 pandemic based on a shared belief that health is a human right. As we near our one-year anniversary as an organization and unfortunately pass the 500,000 mark for lives lost to the coronavirus here in the US, it is more important than ever that we celebrate the work of organizations and individuals leading efforts to represent and serve our communities and their public health needs. We are honored to have Kim Finnessy here, a political consultant and Michigan voter rights and community activist from Detroit, joining us to share her personal story about COVID-19 and why she's joined the fight with Right to Health.
Hi, my name is Kim, and I live in Detroit. I have lost 21 family, friends, and colleagues to this virus. Right now, I have a childhood friend who is fighting for his life in the ICU. His coworker ignored the warnings about family gatherings for Christmas. So several people, including my friend, contracted COVID because of this person's behavior. He began to complain that he was always exhausted. Days later, he said he was having trouble breathing and finally went to the hospital where his health continued to deteriorate. He fell into a coma. He is now awakened from his coma. He's breathing on his own with the help of a BiPAP machine. All of this could have been prevented. My friend believed a lot of the misinformation and conspiracy theories floating around. The distrust of the medical community caused my people not to seek the treatment that they need. The reason for so much distrust in the medical community comes from the history of mistreatment of Black Americans. Most don't really trust the vaccines because of this as well. We remember the experimentation on our bodies without consent. We remember giving shots to prevent fathering children and preventing women from having children. We remember the Tuskegee experiment. Now we're dealing with the lack of care and doctors not believing us when we say we're in pain or suffering. People were told the testing were giving them the virus. So many refuse to get tested. I've heard so many people saying they are changing and stealing our DNA with the vaccine or microchipping us. This is has to stop. More has to be done about clearing up the rumors and releasing the straight facts. Misinformation has led to more sickness and death. We need trusted advice from the people within our communities working to battle this misinformation and connect people to the care they need. Black communities have often been overlooked when it comes to public health, and we must invest now to ensure our loved ones are able to stay healthy in the face of future pandemics. Thank you.
Thank you so much for sharing your powerful story with us tonight, Kim. It really means a lot. We recently held a training and lobby week, as well as our first ever all hands on meeting to recognize the voices of the many people like Kim impacted by and fighting to respond to COVID-19. and to highlight the policies we believe are necessary to put an end to this pandemic and prevent pandemics of the future, as outlined in our People's Pandemic Prevention Plan. One of our 4 key policy proposals is the establishment of a national public health workforce, which is why we are working alongside PHJN members, including Partners in Health, Center for Popular Democracy, SEIU, and ELSOL. We will talk more about our policy vision towards the end of today's discussion, but for now, we want to begin by featuring the stories and contributions of 2 incredible people leading community-driven and coordinated efforts through 2 unique programs. We hope that today's conversation can highlight the power of the community health models, that we can take time to recognize the significant work of COPE and ELSOL before and during this pandemic, and learn from their ongoing leadership in their communities. The work of these and many other organizations worldwide serve as a perfect example for why we need to invest in our communities moving forward at a national level and ensure that everyone, everywhere has ongoing access to support, education, and services from people they trust and know. I want to take this opportunity to thank our speakers and our many Right to Health team members who have joined us for multiple meetings to make this event happen. If you're interested in being involved in our community going forward, we'll be following up with information on how that is possible. Before we dive in, let me quickly cover the agenda for today. Following our panel and audience Q&A, we will invite each of you to join a short small group discussion to debrief, connect, and highlight points of resonance. We have a team of trained small group facilitators who have stepped up to create space for these conversations, and we want to offer a huge thanks to them for taking this on. After our small group discussions, we will once again join together as a large group to conclude our event for the evening. Just a couple of notes on technology. All attendees will be muted during the panel discussion. You can submit questions via the chat at the bottom anytime. We will refer to these questions during our Q&A time following the panel discussion. We are also recording the panel portion of this webinar to be shared within the coming week. After the panel and Q&A, we will share specific instructions surrounding the logistics for moving to small group discussions. With that, let me introduce our moderator for today, Mansoor Khan. Mansoor has been an organizer and activist in labor movement for over 2 decades and has fought corporate interests in higher education, healthcare, and the subprime lending industry. Currently, he is the Assistant Political Director for Research in the Service Employees International Union, SEIU. Thank you so much for joining us and moderating today's panel discussion, Mansoor. I'll let you go ahead and share a bit more about your work, our speakers, and the focus of today's panel.
Thank you so much for that lovely introduction. And I'm really excited to be moderating this very important panel hosted by Right to Health Action. As was mentioned, I've spent 2 decades in the labor movement, really at the intersection of like policy and organizing and how to build movements to create change that benefit working families and working people. And that's kind of why I'm really super excited to hear from our panelists today too, because I think they are really part of organizations that are valuing community input, making sure that healthcare is community driven and is geared towards the needs of the community. So let me introduce them. For today's discussion, we were joined by 2 individuals deeply involved in community efforts to not only respond to COVID-19, but improve our public health infrastructure at the local level. Alvina Bellin is a lead contact tracing trainer at Community Outreach and Patient Empowerment, COPE, which is a partnership with the Navajo Nation Community Health Representative Outreach Program. And Alex Fajardo is the Executive Director of ELSOL Neighborhood Educational Center, a pioneer in community health workers and promoters programs. Thank you for joining us. With that, let's kick things off. Why don't we start? Why don't we just ask the panelists to introduce themselves, and please just describe your organization, your work, your role in community health workers' efforts before and during COVID-19. And I will defer to you guys on who wants to go first.
I think Alvina, ladies first.
Hello, everyone. Good evening. Yate Shea Ya Calvina Belenin. Anani Torichin in Shlon Don my Dishkin Pashin, Tanisan 8-8, Doshin 8-9, I cut out the nest on Shle. Hello everyone, my name is Kelvina. I am identify as a Diné woman. I'm a member of the Navajo Nation. And the Navajo Nation is located in Southwest United States. It's been there since time immemorial, way before Arizona, New Mexico, and Utah became official states. And like Mansour mentioned, I work for Partners in Health and Community Outreach and Patient Empowerment Program as a lead trainer for the Navajo Nation Expanded Contact Tracing Program. I've been in this position since August of 2020. And before this position, I worked as a volunteer contact tracer. When I started, the contact tracing program was already operating for 5 months. And in the beginning, the COPE program, they saw a need for contact tracers as cases were rising on the Navajo Nation. And so they partnered with the Navajo Department of Health, Navajo Epidemiology Center, the Partners in Health, and Brigham and Women's Hospital to start the contact tracing workforce. And so as a volunteer contact tracer last year, I reached out to patients who are, either tested positive for COVID or who were exposed to someone who's positive. And after that, once I became a lead trainer for the program, I assisted with providing training and developing training materials, and most importantly, focusing on making it culturally relevant to my community on the Navajo Nation. The workforce that we work with is very diverse. The contact tracing workforce includes, both non-Navajo and Navajo contact tracers. And so what myself and another colleague who's Navajo, what we do is, provide cultural awareness in our presentations, ensuring relevant information is shared to our non-Navajo contact tracers, so that they are aware of the community that they're working with and are able to effectively communicate with the community as well. And so with the help of the Navajo contact tracers and supervisors, we developed a Navajo language speaking initiative. This initiative's mission is to support the Navajo speaking contact tracers and to advocate for our Navajo speaking patients. And so majority of our Navajo elderly patients, they don't speak English. Navajo is their primary language. And so we have contact tracers who do want to learn or who want to improve their Navajo language skills, so that way they feel more comfortable when speaking to their Navajo speaking patients. And now also to not only improve their self-efficacy when speaking with Navajo speaking patients, but to also build trust and kinship with their patients as well. In Navajo culture, when you're speaking to your relative or to other Navajo citizen, it's customary to first establish kinship with that person. And so, when a contact tracer does that and they identify kinship with the patient, then that patient is more likely to work with the contact tracer and share information. And so that's just overall, an overview of how I started and where I'm at with the program.
Alex?
Yes. Hi, everyone. My name is Alexander. I am the director of a local nonprofit in Southern California, covering like 3 or 4 counties, Los Angeles and the Inland Empire. And our work is to empower communities to eliminate disparities and to create social change. So how we do this is through the concept of community health workers or promotores. So we recruit people, they live in the community, they speak the same language, and we develop kind of empower this community to become leaders in their communities. To do health-related work, but also to become a mobilizer in their own communities to create change, social change that they need. We recruit those, they have the passion on their community. They speak the same language. Most of our community health workers promotores are from the Latino community and the African American community that live in the community. Muted now, okay. And then one of the things that we were doing before COVID, it was doing different programs from the spectrum of prevention, from individual to policy. So we have community health workers, promotores working at community outreach. We have promotores doing health navigation, case management, even working in clinics. So we have different roles from the community health workers. And then when the COVID-19 came, so everything changed and we start developing a spectrum of activities that they will be doing. So we develop training to be cultural sensitive and many topics for COVID-19 and recovery. And we have now implementing kind of activities for the COVID-19. So we do outreach, we do education, we do social and mental health support for those that are being positive from COVID-19. We have been doing testing, some of the community health workers being trained to do testing, different places in rural areas. And now we are moving towards the vaccination. And then we are preparing for recovery and healing phase after the pandemic ends. So we believe that the community health worker and promoter is an expert of the community. So in my staff, I have a public health experts, I have a medical experts, I have a financial people that are experts, but they are the community health workers are experts in terms of reflecting the needs of the community and making decisions there as part of the expertise group that we mobilize. So I think one of the things that we are doing or we have been doing is to keep in mind that we deliver a service, could be mental health service, could be a contact tracing service, could be a education service. The agency is mobilizing all of the community workers to create a social change. So it's not just providing information on education or service to someone, is really how we can empower communities that they can stand up and defining what they are their needs and how they can organize themselves in order to create the change that they want to have in their lives, but also in their own communities. Because it's not just giving, as an example, an asthma class. We do asthma and we do asthma management. But maybe that person make changes in their own house, but what about in the area? You know, like I think that's the phase Del Sol is doing, trying to mobilize all of the community workers to create this kind of change within their own communities. That's kind of an overview of what we do. We have different programs, mental health programs. We have social support groups. I mean, we have tons of programs, so I don't want to mention about the programs, but I think that's kind of the overview, the general overview.
Thank you. So Alex, I have a question for you about how has the pandemic affected how you guys have been doing work or shifted your program, like, and what are some successes you could point to or challenges you faced because of the pandemic?
Sure. I think the first thing, it was changing our way to do things. You know, most of the people are doing work in the community, doing their programs with the community lives. And now with when the pandemic came, we have to switch and make it more like how we're going to be doing our work. So we moved to phone calls And then after that, we start developing some trainings for the staff to do kind of Zoom or any other technology, because the community were not ready. So they need to train the community how to open an account with Zoom, or how to use Zoom, or how to use YouTube Live, or those kind of things. So I think it was a movement of training the community workers promotores so they can train their own communities in order to gather. So I think that's one of the things that we develop, kind of a training and developing these support. I think another thing I want to highlight is I have to bring a mental health consultant for my staff. So I was able to have someone, and then I say, okay, I'm gonna giving you, I don't know how many hours, I think it was 300 hours of commitment. And she was coming to the groups of my staff to reflect, to give us kind of create this space to talk. And also we provide one-on-one to my staff, because they were losing all the lifestyles, but also losing maybe people, family members, some things like that. So we need to have this support. So I need to strengthen my staff in order for them to do the work in the community. So I think that changed. I think now it's almost 1 year after we after we start doing everything online. And then I think we have been seeing the improvement across the board, how to handle the change and how to reflect on it, how to make change and how to adapt. And that happens with the communities too. So we create kind of this space within our communities to reflect on it, because the pandemic has been moving so fast that no one has been having time to see it and reflect and, you know what, wow, what is this going on? So I think that's something that in somehow affect us, but also develop some resiliency in order to present any circumstances that can happen. So I think it's a preparedness project that we went through this year in order to be prepared for other emergencies that may happen.
Cool. All right, thank you. Khalid, I know, so similar question, but like kind of, I know Alex mentioned, and you mentioned cultural competencies and having experts and making sure that the community members are seen as experts in the work you guys are doing. What are the challenges that you think you face when in ensuring that the community's voices are actually, and community members and expert voices are heard and respected as you encounter the healthcare system?
I think one of the main challenges is how COVID has affected the community as a whole, and that challenges the response of the organization, how they should, respond to the outcomes of this pandemic. As Alex kind of mentioned, COVID is changing, so priorities are also changing as well in the community. There are voices that have different priorities, and so adapting to that is in itself is a challenge from an organizational standpoint. For example, one of the main things, as contact tracers, we tell our patients to go into isolation or to go into quarantine right away. And that in itself is really hard to do because you also have to take consideration of their basic needs like shelter, food, water, and supplies and that kind of stuff. And therefore, another priority for us as contact tracers is to ensure that our patients have the resources that they need in order to isolate or quarantine safely and successfully. And so we spend much of our time and our training on linking resources to patients. And I also want to mention, I think another challenge from an organizational standpoint is ensuring that our training is using a culturally responsive approach. As a trainer or as a supervisor, we have to recognize and incorporate the Navajo cultural assets and strengths into the program. Not only are we thinking about things like cultural competency, or cultural community, but also, just working with our contact tracers and those within the community to ensure that we are being respectful to the community that we're working with in everything we do. It does take time and effort to tailor the training and the materials and all of that, within the program.
Is there something that you could speak to that's like you felt was like a real success and the way that people should be modeling these sort of programs? This is Calvina, just a follow.
Successes of the program?
Yeah, some example of where you're like, okay, because we did X, X, Y, and Z, and like some best practices that other people might be able to.
Right. And so I think one of the successes that's been working really well, and I kind of mentioned this earlier in my intro, is incorporating culturally appropriate practices, materials, and developing communication campaigns that's relevant and that speaks to the community. As a team, for example, we had to tailor our scripts, the contact tracing scripts. We had to be very mindful about the language that was put into those scripts, especially conversations around topics like health condition, symptoms, or even death. And so that's just, an example of making sure that we are being culturally appropriate to the community.
Thank you. Alex, similar question. What are the sort of challenges in your at El Sol that you guys face in making sure that community voices are incorporated into their own health?
Sure. So what happened at the beginning was most of the community health workers were doing phone calls, like how's everything, and then we just developing strategies in how to support those families if they need food. So we were able to do drop-off food or whatever. But through that conversation, many of them start opening up and say, you know what, my husband or my uncle or anyone has a COVID-19, no one knows, and he's going to work, because if he doesn't work, we are going to be losing the house or anything. So I think that creates us like a red light. Okay, how we can support those especially those immigrant communities that live check by check, and then if they lose one day of work, is not gonna make all of their. So I think what we developed was kind of another group of community workers that were doing just COVID-19 positive cases. That was at the beginning. No public health department were involved. This is just the work that we were doing. Now we have a structure and those kind of things, but at the beginning was more like having this kind of support, and that gave us experience in how to advise the public health departments to implement something similar. So I think the main challenge in terms of the question about the how we can let the voices of our communities be heard and respect. I will say that they need to be part of the decision making. It's not just saying, okay, they need this. It's not like we invite them to be on the table and say, this is how this is what I need and how I need it. It's not just what you need, but also how. And then I think having that conversation with the people who make decisions was kind of some challenge in order to raise the voices of our community members to be heard on the policy tables. So for example, right now through the testing sites and also to the vaccination, we were able to advocate and inviting community members, and they are telling the people how they want to have, when they want to have the testing site, how, which day, which hour of the date, and who will be there, how often. So I think they are making those decisions and for the testing site. Now for vaccination, we are doing similar. it's other structure, but we are advocating to let, this is how the community wants to do the work, instead of us telling what to do. It's better if we invite them to be part of the decision, and then it's not just for the vaccination or the testing, is also for their own lives. How do you want to do it? What is needed? Which steps do you need to do this? So I think that has been one of the challenge, but at the same time successful because we were able to make changes along the way to do this kind of work, especially through COVID.
I know you also mentioned when we talked, Alex, about incorporating popular education programs. Could you speak on that a little bit, on how you use popular education in your programs?
Sure. So we develop new, especially the materials that we give and which tools we develop in order to educate community members. So we use popular education. This is kind of ways to have a reflection on what is happening, and also that we learn from each other. And so we use things like, for example, popular drama. We have been developing some popular drama. So our promoters, they go and do a drama of a theater drama, popular, and then maybe they let us to do in a mall or in a park, and they do like 15 minutes of script, and the people just get there. It's like kind of funny, but at the same time we're educating. And we do like a puppet show for people for kids, and then some of the schools invite us to do kind of 15 minutes about the scripts, about how to prevent COVID. Today we are releasing our song. It's going to be in Spanish, and then I'm willing to share with all of you. It's a song that talks about face mask, distance, testing, vaccination, in some level, to the people can reflect and educate. And also from that song, that is like 3 minutes, we cut it, and then I can share it here if you guys want it, but they can cut it by messaging to do radio spots. So we're trying to do that through radio as well. So things like that we are doing. We develop like a bingo game as the bingo, we call loteria in Spanish. And that's kind of a game, and each of the cards is about COVID, how to prevent it, what is needed, those kind of things. And we give it to the families, and the families play with their own family at the bingo game. So things like that are helping us to be able more effective, and also developing that trust. Many of our community members, they don't trust even the doctor. They say, the doctor doesn't know this. I'm not drinking my pills, but the doctor thinks I'm doing it. But and they're able to share that with the promoter or the community health worker. And with that trust, we develop this kind of, okay, let's do the change step by step. But you do it. I'm here to support you. I'm not here to tell you to do it. I'm here just to support you. I create some space of reflection. Why? And then that person start making their own changes. Instead for the promoter or the doctor say, hey, what you don't change your diet, as an example. But I mean, it's easy for them to do that because they have all of the resources to do it, but maybe this person doesn't have. So I think that reflection process with the promoter being hand by hand with the community member makes these kind of things to reflect on it and make their own changes.
Thank you. Kelvin, do you use any popular education models in the work that you're doing? Or I know that you've also talked about challenges of translations between the language. If you could speak to both of those, that'd be.
Challenges of languages.
Like, I think you were mentioning how some of the challenges you faced in being community around just translating between Navajo and English, and how you overcome some of that.
Yeah, And so with that, I mean, that is a challenge, especially having to establish a contact tracing workforce that didn't exist before the pandemic. And so, you know, a program like COPE, you know, they had to quickly establish a workforce in a short amount of time, and then developing scripts, like I mentioned earlier, you know, and Navajo language was, you know, definitely did take time. And we were thankful, you know, to have contact tracers who do speak Navajo. And, you know, they were the ones who advocated for their patients. And so, and they requested that, you know, we have initiative that supported them, and that, you know, we meet every week for about, we meet 3 times a week for an hour to work on our Navajo language skills. And we're finding that, you know, some of the words like vaccine don't exist in Navajo. And so we just have to, you know, kind of listen out to other community members and how they're saying it, so that, you know, everyone understands. And so that's one of the challenges. But at the same time, you know, we're working every week, you know, to making sure that we are providing, you know, the language to the people when we're talking to them, either if it's over the phone or if it's giving out, you know, communication campaigns to the public, just making sure that, you know, it is translated in Navajo and that it's possible.
Okay, so I think you mentioned the workforce piece and like how you had to get this up and quickly, and we desperately need more healthcare workers in this, and community health workers. So I wanted to sort of, you know, we were brought together because we're all part of a coalition that's fighting for public health investment and public health jobs. Alex, do you want to just talk a little bit about that coalition work that we've been a part of?
Sure. Yeah, I think this coalition, it's very powerful. It's the public health jobs now. I think that's the website. And you guys can look at it if you want it. I think I enjoy this effort because I believe the unifying our voices is very powerful, but especially because this coalition is to advocate for community-based workforce in terms of trying to empower those community health workers, promotores, and how they can do, because they live in communities, they speak the same language. So having those resources coming directly to them will be beneficial to really overcome the challenges that we are facing through the pandemic, but the future, because I know the pandemic hopefully will end soon. I'm hopeful for that, but I think the next phase is about healing and recovery from that. So I think that those resources are needed to heal our communities that are going to be having through issues through after the pandemic. And then I think the voices, they are unifying the voices is very powerful from each of the partners as well, getting kind of a specific concepts that we are asking for. That's very, very powerful in order to mobilize our voice to bring power to the communities.
No, yes, and you know, I think as I just want to add that, you know, SCIU is a member of this coalition, and our members do work in the public health departments. So not necessarily in the community health workforce, but we've noticed like the disinvestment and the way, you know, how the lack of investment in public health, whether the community health worker level at the public health department level, has sort of, you know, hampered our efforts in managing COVID, and we desperately do need more investment. So So I just want to like, raise that again as something I think, when people go into small groups, maybe, it's something that Right to Health has been super active in as well. And they've really been a core partner in this coalition. I want to sort of raise it to both of you. Like, we've talked a lot of things, like how do people get involved? What can people do to support the work or even join these efforts? Or the pub, I know that people can go to public health jobs now. Fighting for the public health job corps is a really important piece, but how do people support, if not your organization, other organizations that are, working with in the community health space with like really elevating the voices of the community and, doing this in a culturally competent way?
I think I can jump into, I think one of the things that we can do as a team, as this group, is really trusting the community in terms of that they can do their own changes and giving that power to the community. So, okay, you guys are gonna do this, let's do this. And that's one part of kind of developing this and also supporting any effort that is happening from the community, from the bottom to the top, in my opinion. So let's support that because that's is gonna bring sustainability. Because when it's different, I mean, when it's top to down, sometimes, okay, they do the work until the funding goes, and when it's finished, it doesn't maintain. But when it comes from the community, they will sustain anything that they create for sustainability purpose. So I think it's analyzing what is happening in your own communities, which groups are doing the work, supporting them, facilitating with funding, with support. I don't know, which each community has their own needs, and then developing that kind of empowerment process. And if they want to do this way, let's do this way because that's the way to do it. Maybe we facilitate discussions and things like that, but let them to take the ownership of their own changes, and that will maintain in sustainability. That's one part. And the another part, I think, it's doing more kind of advocacy part of locally, city or county or state or nationally, about developing these kind of principles that are being successful in some communities if they do it right. So I think that's how I wanna present in terms of supporting.
Calvina?
So how can we support this work? Was that your
How
question?
can people support? How can people support this work, or even join these efforts, or how should we think about community health workers and providing healthcare in the sort of culturally competent way that you guys are doing?
I think one is using this program, the contact tracing program, using that as an example, for how community-based healthcare or community-based public health programs, how that can be used as a model, outside of COVID-19 pandemic, with the experiences, that we gain and the experience of working in the middle and bridging, that connection between the people and the healthcare workers. I think this kind of program has been proven that it is possible to bridge the gaps within our healthcare system. And I think another thing is that is to also understand how and why COVID is significantly impacting Indigenous and Native communities in the United States. And so for one example, I would say, is just learning how our community has been negatively impacted, by the intentional and harmful past policies that were placed, by the federal government. This invisible monster, this COVID-19, has revealed will reveal how past policies has led to current health inequities among Indigenous and Native communities. And we are witnessing it right now within our own community. And so my hope is that, majority of the support will be committed to the long work and efforts of building an equitable and fair relationship, with the Indigenous and Native communities within the United States.
Okay. I think we can take this time to take some audience questions, I think, if you guys are up for it. So I think, one question we have, I guess I can start with Alex first, and Calvina, you can also weigh in. How do you identify and empowered and trusted communities folks? What is the process? How do you go about doing that?
When you say identify, that was the word you say?
Yeah, identify. How do you find what's the process of who you think will be a good community expert? I know there's a big training program, but how do you go about recruiting folks?
Sure. I think one of the things, most of my promotores community health workers has been part of any of the programs. Most of them, not all of them, but so if a promotora is talking about domestic violence, and then from those groups that she's doing the intervention of this kind of work, many of those moms want to become one like her. So I think that's how we are able to gather, because it's a experience that they went through and say, this project is working and work for my life, and then I want to do the same thing for others. And those when they are being going through the process of being impacted by any of the programs, they are the most successful to impact others, because it's a testimony live. And that's, I think, is a key of this philosophy that we use, because the experience is a powerful tool that changed lives, that changed behavioral. It's not just I took a class and then okay, now I have the knowledge, but I think the experience. But I think that one I went through. I was a victim of. I have a depression, and now through this focus group or support groups or whatever, I was able to overcome. Now I'm here to help others. So I think that has been one of the most successful part of our interventions, because it's that experience is that what weights kind of my speech. It's not just the good speech, but not really life change. So I think now it's connecting what you talk with your own life. So that it's powerful, and that transformed communities, that transformed lives. And then I think that's how we're able to recruit. And now when we go to do the work in another aspect, I mean, they because they live in the community, say, hey, I'm here, your neighbor, I live here, my son goes to this place. They don't even present and they say, I'm a promotora from the Sol. They start talking and say, oh, and then, by the way, do you know this? By the way, do you know the vaccine is coming up? Now with the seniors, we are going through, so we're trying to get seniors that were already vaccinated, and they are calling their neighbors to educate them. That's the main aspect. Oh, I did it. Didn't happen anything to me. This is my second dose, and then I have just these symptoms. Why you don't do it? So I think that experience connect with others in order to take actions.
I think same thing, Calvina. How do you when you bring in the contract tracers? What's the recruitment process, or are you bringing in community leaders as well into the contract tracing program?
I agree with what Alex said. I think listening to the community is first most important, and also listening to our contact tracers as well, because they are from the community, and so listening to them and because they're also experiencing what their patients are going through. And so, you know, they know what it's like, you know, to have to isolate and quarantine and also when grieving for, you know, your family at the same time you're working. And so, you know, working with them side by side is important, where we can gather, you know, what their inputs and what we can do to help. And I think in addition to that, for Indigenous and Native communities, you know, we also look towards our elderly and our leaders in our community. Our elderly are sacred, you know, they are the knowledge keepers in our community. They've experienced, you know, a lot of hardship in the past. And so they know what to do, you know, they know how to cope with something like this. And so, and they've also have the traditional, you know, practices and culture, you know, and how to regain balance and harmony again in your life. And so those are, you know, examples.
This is actually a question for Calvina. So it's, I'm just going to read it the way it's written. How do Navajo contact tracers work with border towns or off-reservation spaces where Navajo members live? Does contact tracing look any different if you cross over into public land?
So I know, because right now I am living in a border town. Right now I live in Flagstaff, and the Navajo border is just right there. And so for border towns, I know, for example, like Flagstaff, you know, they have their own contact tracing program. And so, you know, if they have patients who are Navajo, you know, the county here in border towns will actually reach out to them. And then another example is, because for the expanded contact tracing team, we started out with the Indian Health Service that's actually in the border town in Gallup. And so we do have patients who overlap, who live, you know, within, outside of Navajo Nation that live in Gallup, which is a border town. And so majority of, you know, the contact tracing efforts are working with patients who are registered with the Indian Health Services and clinics on the Navajo Nation. And so there is definitely some overlap, but again, there are counties and border towns that are doing contact tracing on their own.
I think this is a question for Alex, and it's close to my heart because I live in Los Angeles. And it's just, do you work with the unhoused community on Skid Row? Are you able to do that? Is that part of your?
I think that community, that specific community, no, but in San Bernardino we have a strong homeless population. So I think one of the things that we were able to do maybe 2 months ago, we create kind of, especially when the numbers were going up, and then we have to do some action. So what we were able to gather was kind of a specific resources for them, like hotels that they pay a few days, or things benefits, because sometimes we do outreach, especially for this specific community, but we are not prepared to provide the support that they need. So I think anything that we do, and what we do is kind of we bring food truck, you know, like a lot of food, water. They are there, and that's the moment that we provide information, and we have resource tables. Like, okay, if you want to have insurance or health services, this is the table. If you, and that's a lot of I think it's kind of health fair to wherever they are, but we need to be prepared to be to provide the services that they have. Even though one time we were able to bring like a showers, so they were able to take shower there, and then that part. So I think it's kind of we have been done some work with the homeless population. It is but there needs to be a specific target and approach.
is there a big, what are some of the key big differences in working with housing versus homeless population?
No, it's totally different. I mean, this is with houses. You talk about COVID-19. Homeless, you have to tell to make sure that they are not hungry. So you have to provide, if they are hungry, they don't supply their needs, they are not going to pay attention about it. So I think it's better to providing that what they need first, so they feel. That's why with the food and then after we start talking, hey, can you bring this? I think that's how. And also, it's with the houses you do door to door. It's about the relationship on that. Even though, for example, our building in San Bernardino, we have a lot of homeless in the area, and they are the ones to take care of the buildings, because they trust. Hey, Alex, something happened here. Hey, because we develop some other kind of relationship. So kind of, hey, instead to fight against them. Like, I'm gonna call the police because you are behind on my building. Why we don't? And then that's another way to create relationships. And now they are the ones they come to say, hey, I have this issue, I have this situation, even though we have to put some boundaries and things like that to see. But I think it's very interesting. For example, we have a other homeless person, but we were able to create like a little house in the back, and he lives there, and he has 2 dogs, and he take care of my land that we own, and he was the one. So I think, and then they trust that we are here not again. We are because most of the neighbors, they call and fight with them, and we are here to support them. So I think it's another strategies to work. Even though we did some focus group with them, we invite them and say, hey, can you give me 20 minutes of your time? Let's do this. And we were to the park. We do a focus group to gather information from them to see how they can be, we can help them in the way that they want it.
Okay. So I think we're going to do one last question. This is actually specific to the health force bill that we mentioned. And I'll read it. It's from Chris Norwood. How is the health force bill working to ensure that funding actually goes to community groups instead of being diverted by hospital systems and large, quote, nonprofits, which are businesses? That happens often. I mean, I have thoughts on this, Alex, but do you have any thoughts on, as a community group, working with community health workers, what are your thoughts on how we're going to do this?
I'll let you, did you want to talk? Did you want to give your opinion first?
No, I can. I mean, so, I think part of this is like, there's a couple of challenges. One, because the health force bill ended up being included in this first round, at least through the process of reconciliation, and we don't need to get into what that means, but it means that there's very little you can actually like direct in the language to say it needs to go to X, Y, and Z, and so it's designed to go to public health departments. Our goal is to sort of work with the CDC to offer guidance, and then I think we made it as kind of flexible so that like communities on the ground will then can go to their own public health departments. Like the idea is that like we want it to be flexible for different situations. So like, Inland Empire will have a different set of needs than say the Navajo Nation, say than like, Skid Row. And so like we wanted to make sure that the money can flow to community groups through the public health departments. But I think it will have to be at the local level that we all have to be sort of organized. Like I think that's like, for me, that's always been the key. Like how do we organize? Otherwise, legislation can only do so much. They can't, as I think the question implies, health systems are much better funded and have more lobbyists, so they end up getting the money. And so we just need to have more people power and people on the streets and people going to visiting. But that's my take. I mean, I would love to hear from both of you on what you guys think the role of, organizations such as yours can play in making sure the money goes to the right place?
I think one of the things is not about getting the money to the CBOs. I think that's important and that's something. But I think the next phase is giving the flexibility of the money, because the money, you can say the public health, the department say, I give it to the nonprofit, but they give us what they want to do. Sometimes what they give us, what they give us what they want to do is not what the community needs. So I know the goal is this. Give us how we get to this goal is up to us. Trust. That's why I use trust the community as part of this group. Let's the group to decide how they want. I know you want to improve vaccination. Okay, let's do that. But let us to make the decision in how the objectives and activities. I know the goal, but the objectives and the activities, let us to do it. So and give us the flexibility to. And then I'm pretty sure that the results will be, I don't want to say better, but it will be more sustainable because it's empowerment, community-based organization. The another thing, I think the question, it was also about the big nonprofits versus to the to the community-based organizations. And that's another thing that we need to start advocating, because being a nonprofit doesn't mean that a person is a community-based organization. I'm not, we call it's a nonprofit, it's a community, but it's two different things and concepts, because you can be a nonprofit and having the structure and not being a community-based. So each community, they need to develop their own programs. They need to create their own programs, and they need to, how do you say, they need to birth their own programs. No imposing for someone else. Those programs are the most powerful programs. So for example, I'm gonna give you two examples quick. For example, we are serving, even though we serve the same region, but each community is different. For example, in one of the areas, I have communities from Mexico that they don't speak Spanish. They speak Purépecha. Or I have communities that they are from Guatemala and they don't speak Spanish. They speak Mom. So I having those people involved in making decisions. So we are able to recruit one of them to be the trainer, and they are doing the program. But I'm not telling them, you have to do this flyer because this is what you have to do. No, we are creating this. Okay, this is what we have to do. How do you do it? And then I trust that leader, that person, in how to create the flyer. Now we help creating kind of a nice way, but it's not just, and also as giving the advice about the information is true and accurate. But I think that's how it is. For example, we create a flyer, we put flyers indoors for the rest, but for this community it doesn't work. So we have to create like a little, she make us to create a little thing that they made, and it's very nice. It's a small thing. And then instead to invest 1,000 in printing, we invest 1,000 in those little things, and they just put it here. And then I say, I'm cured, whatever they believe. So that's things of being flexible with this one. And I think that I want to reiterate about the difference between being a nonprofit and really a community base. This is an example, and hopefully, I think how we are, that's why this group is for. Hopefully we get there in order to let advocate for making sure the community-based organizations are getting some of that funding, not all of it, but some of it to do some work as needed.
Right, and I think to your point about like local control, like we did try there because of the reconciliation process. We were looking for like boards, community boards controlling the funding. That it just isn't possible in the way that the bill had to be passed through the Senate. Well, thank you all. Would you guys like any last words? Because for me, this was like an extremely learning experience. But if you want to, anything else to leave our audience with before we move to small group sessions or the next part of this program?
Calvina,
Okay.
you wanna go?
Yeah, just really quickly, wanted to mention also how we can build on this work. I think that, the main area of this work, which is like the overall goal for our program for Navajo Nation, is just focusing and on building and training a public health workforce, that is led by the NEC community, led by the Navajo people. And so, Alex mentioned earlier, it's about empowering the community. And so for a public health or healthcare program to be successful in any community, it's so important that it is led by the people of that community.
Sure. I just want to finalize this about the community empowerment. It's not just giving a flyer and educating, it's really empowering the voices, because if we unify voices, we're going to be influencing. But I know there is, for example, a comment about the diabetes. So I know the issue with diabetes, and then they give us the curriculum 300 pages and we have to follow those. So we were able to get unrestricted funding to do our own diabetes. I just want to give you this example. So we received this kind of diabetes project. And the first thing that we did was the community health workers and the promoters, they say, okay, the evaluations are not working because the community, they don't even have those 3 pages evaluation, yes, no. So they develop like a dibujo voice or drawing voice, like the pre and post, and the evaluators have to change the way to, and also they increase the AC1C3. I mean, a powerful example when we, and we use the CDC and modified it in the curriculum. We modified it. This is to structurally develop this way, even though with the same objectives. We are not changing the objectives. We're changing the activities, and we're not changing the goals. We're changing the objectives and activities and how to get this goal. I think that's how it needs to be happening.
I think that is a great way to end, and a good example. So thank you both, Calvina, Alex. I learned a lot. I hope everyone else did. And I will turn it back over to our host at Right to Health Action.